Hello everybody, and welcome to another one of my USMLE World review lectures. I'm going to be discussing gastroenterology, specifically on pediatrics, gastroenterology for surgery, as well as obstetrics and gynecology. So these are just some of my high yield review notes that I took from UWorld, kind of compiled them up to make sense, and this is a continuation for the gastroenterology notes that was more focused on internal medicine and the generalized broad spectrum of that subject. So we're going to start off with pediatrics, and these are going to be the water-soluble vitamin deficiencies. So under the vitamin deficiencies, I guess we're going to go through each one of them. Well, not all of them, just B1, B2, B3, B6, B9, B12, and C. Okay, so vitamin B1, thiamine. The source of this is going to be through whole grains, meats, fortified cereal, nuts, and legumes, like lentils and stuff. And the deficiency in B1 is going to give you your beriberi, which is either going to be a wet beriberi or dry beriberi. The dry is going to be the peripheral neuropathy. The wet is the heart failure. Wet because it's full of blood, right? Blood's wet. And dry peripheral neuropathy. So that's the beriberi associated with thiamine deficiency. Also, Wernicke-Korsakoff syndrome is associated with B1 thiamine deficiency. All right, next one we have B2 deficiency, which is riboflavin. Riboflavin deficiency causes angular chelosis, stomatitis, glossitis as well, and it can present with a normocytic anemia as well as seborrheic dermatitis. And the way you get B2 is through dairy products, eggs, meats, and green veggies. So remember, riboflavin for the angular chelosis is the one that they like to ask. B3 is your niacin. And the source of B3 is going to be, again, through meats and whole grains and legumes. A deficiency in B3 is going to give you pellagra. That's the classic one. They're going to present with a patient that has some kind of a rash, like dermatitis, has diarrhea, dementia or delusions, and glossitis. It doesn't have to have all of those, but they'll probably present with at least diarrhea and dermatitis. Maybe even give you a little bit of like headaches or kind of something along the lines of delusions or dementia. And you should pick pellagra as it. Okay, then B6 is your pyridoxine. These are going to be found in meats, whole grains, legumes, and nuts. So as you see, if you see a pattern here, you're going to want to start eating meats, whole grains, and legumes, right? So B6 deficiency also can give you chelosis, as well as stomatitis and glossitis, and it can give you irritability, confusion, and depression. All right, so that's B6. B9, which is folate deficiency or folic acid. Well, it's not deficiency, it's B9 is folate and folic acid. A deficiency in folate or folic acid is going to give you a megaloblastic anemia, as well as neural tube defects in the fetus. But the source of B9 is going to be in green leafy vegetables, fruits, meats, and fortified cereals and whole grains. B12 or cobalamin, this is going to be specifically in dairy products and in meat. And a deficiency in B12 will give you your megaloblastic anemia, just like folate does. But B12 can also give you neurological defects such as confusion, paresthesias, and ataxia. And then finally we have vitamin C, which is ascorbic acid. This is found in citrus fruits, strawberries, tomatoes, potatoes, and broccoli. Deficiency in vitamin C can give you scurvy. And scurvy is going to be your punctate hemorrhages in your scalp or in your hair follicles, gingivitis, as well as a corkscrew looking hair. Now, toxicity of water-soluble vitamins, that's rare, but Out of all of them, pyridoxine, when it's in excess, can also cause peripheral neuropathy. So that's a good one to remember. All right. So next up, we have pediatric abdominal wall defects. So what are some of those abdominal wall defects? You have your umbilical hernias, gastroschisis, and omphalocele. Those are going to be your three most common ones, or testable ones. So you have your umbilical hernia, which they're going to present with a defect at the linea alba, and that's covered by skin. Sometimes it contains the bowel, sometimes it doesn't, and the umbilical cord is going to insert at the apex of the defect. That's your umbilical hernia. We're going to go into a little bit more detail on each one of them, but these are just the bullet point topics. Gastroschisis is going to be a defect to the right of the cord insertion, and it's not covered by a membrane or skin. It contains bowel, and the umbilical cord is going to insert next to the defect. And then you have your omphalocele, and that's a midline abdominal wall defect, and that's covered by peritoneum. It contains multiple abdominal organs as well as an umbilical cord that inserts at the apex of the defect. So an umbilical cord that inserts at the apex of the defect can either be umbilical hernia or an omphalocele, but if it inserts next to the defect, it's a gastroschisis. And then gastroschisis is the only one that is not covered by skin or membrane. Omphalocele is. Okay. Now, more in detail on umbilical hernias. Umbilical hernias are going to be an incomplete closure of abdominal muscles around the umbilical ring at birth. It's very common in African Americans. Also, it's common in premature births, as well as Ehlers-Danlos syndrome, Beckwith-Wiedemann syndrome, as well as hypothyroidism. So those are the presentations you should remember for an umbilical hernia. Prematurity, African Americans, Ehlers-Danlos, Beckwith-Wiedemann syndrome, and hypothyroidism. A small umbilical hernia is typically going to close spontaneously on its own by concentric fibrosis and scar tissue formation. So that could be a test question. You can feel this kind of umbilical hernia. What do you do next? And it's going to be, you're going to just want to observe and give them conservative management or whatever, because it's typically going to go away on its own. The spontaneous closures are going to be less likely with large hernias. So large meaning more than 1.5 centimeter in diameter, or in patients with any kind of underlying medical problem. Surgery is going to then be recommended around the age of 5 if the hernia has still persisted and it hasn't gone away on its own. Also, if it's just bothersome or causing any kind of complications, you'd want to fix that through surgery as well. But if by age 5 it hasn't gone away, then you can consider surgery. Other than that, they should go away on their own. All right, next up is gastroschisis. This is caused by a vascular insult to the causing a bowel herniation. So the vascular insult is going to cause a bowel herniation, and a second trimester ultrasound is going to be more than 95% sensitive to see any type of abdominal wall defects, as well as the maternal serum alpha-fetoprotein, which is going to be elevated in gastroschisis. If you see this, the bowel is going to be exposed in the amniotic fluid, and this can cause inflammation and edema of the bowel wall because it's just not, it was just not designed to be floating around, getting in contact with anything else other than your abdominal viscera, right? So in this case, it's just it's outside of the abdomen. There's an increased risk of complications because of that. They can cause a necrotizing enterocolitis as well as short bowel syndrome, and that's because it's not relaxed in there. It's dry and it's getting contracted. It's getting fibrosed, and then it can actually cause a necrotizing enterocolitis as well as short bowel syndrome. All right, then dysmotility can also occur in more than 50% of cases, like ileus or delayed gastric emptying and intolerance to feeding. And that occurs in around more than 50% of the cases, like we said, and it can prolong reliance on TPN. So they're going to have to be reliant on TPN for a longer time. And it is an isolated defect in more than 90% of the cases. It's just in that area. And the treatment is that after delivery, you're going to want to immediately cover the exposed bowel with some kind of sterile saline dressing and give it a plastic wrap to minimize the insensible heat and fluid loss. Then you're going to also place a nasogastric tube to decompress the bowel and start them on antibiotic therapy to then prompt any kind of surgical repair, because that's usually accomplished in a single stage closure. Then you have your omphalocele, which is approximately half of the patients with omphalocele. They're going to have some other coexisting defect, like they're going to have cardiac diseases or neural tube defects or some kind of trisomy syndrome. So look for those as well. And then treatment is to do surgery immediately after birth by a staged closure of this with a silastic silo. So it's the silo thing. So you don't want to just close it quickly. You want to start closing that area in stages. All right. That's an omphalocele. Next up, we have an umbilical granuloma. And this is a common cause of an umbilical mass in newborns. And it can appear after the umbilical has separated. And it presents as a soft, moist, pink, pedunculated, friable lesion. The treatment for an umbilical granuloma would be silver nitrate. That's the treatment of choice. All right, so continuing on, we have now the differential diagnosis of crying infants. So there's some diagnoses that are related to a crying infant, like colic. There's gastroesophageal reflux disease, corneal abrasions, hair tourniquets, a milk protein allergy, or just a normal crying infant. So let's go through the clinical features to differentiate each one. So for a colic, this is going to be a crying infant that occurs in an otherwise healthy infant, or crying that occurs in an otherwise healthy infant for more than 3 hours a day. And it's usually seen in the evening after they've already eaten, right? More than 3 times a week and for a duration of more than 3 weeks. So that's what colic would look like. In a normal infant, crying usually goes away with counseling methods, and it just lasts for less than 2 hours a day, once or twice a day at the most. So colic is happening more than 3 hours a day in the evenings, more than 3 times a week for a duration of more than 3 weeks, right? Because a colic is going to be one of the most common causes of crying infant differential diagnoses. The other one would be GERD, or gastroesophageal reflux disease. Here in the question, they'll describe an infant who has arching of the back during and after feeding. That's your Sandifer syndrome. They're also going to have frequent spit-ups or vomiting, and they're also going to have poor weight gain. So just look at those for GERD. Now, corneal abrasion, that's easy. You need to do the fluorescent examinations, or positive fluorescent exam is seen in corneal abrasion. For a hair tourniquet, hair tourniquet is when there's an actual, like a strand of hair that is accidentally tied up or wrapped around an extremity or a digit, causing there to be pain in that area. So they'll be crying for obvious reasons. It's painful. Milk protein allergy, you're going to see blood-streaked mucousy loose stools, or you can see severe constipation. So that's for milk protein allergy. Now, the crying time of a normal infant, like we said, is generally between 1 to 2 hours a day, but it's pretty variable. Versus colic, remember colic is various more than 3 times a day. Colics usually present within the first few weeks of life, and they spontaneously go away by their own on their own by 4 months, and generally they are going to be crying during the same time of the day. So remember, it's usually in the evening for colics. The etiology, usually it's unknown, but it could be also due to overstimulation of a baby, or there could be a parental unfamiliarity with soothing techniques. Parents are going to report difficulty or frustration whilst trying to soothe the baby. Calming techniques are then encouraged, so swinging the infant, swaddling them, also minimalizing environmental stimuli, like putting them in a quiet, dark room and holding the baby while rocking them. That's a good calming technique. You want to review the feeding patterns to assess if there's any type of overfeeding or underfeeding, or if there's any type of inadequate burping techniques. Colic is associated with an increased incidence of non-accidental trauma. Also, postpartum depression is associated with colic. Parents should be emotionally supported and reassure that their child is healthy, and you want to review their soothing techniques. Also, something that's encouraged would be to do breaks. So breaks are encouraged, like for like handing the baby to a friend or a family to babysit the child. That's encouraged. All right, next topic is foreign body ingestions. Patients are going to present with difficulty swallowing, obviously, feeding refusal, and vomiting. So if any of those present, think of a foreign body ingestion. The management of a foreign body ingestion really depends on whatever was ingested and where it is in the GI tract and the timing of those durations of the symptoms. So for instance, the most common one that gets tested is the coin, right? That's the most commonly ingested material. It's visualized within the esophagus. Now, if it's symptomatic, then, and you don't know when it was swallowed, then you want to remove that coin very quickly with a flexible endoscopy. Now they're going to give you the flexible endoscopy or rigid endoscopy. If they give you rigid, remember rigid has a higher risk of perforation and an abrasion than a flexible one, so they prefer flexible endoscopy unless there's some kind of sharp object that's impacted in there where you require more rigid endoscopy. Otherwise, flexible endoscopy. However, if you do get a question with an X-ray and you see that the patient is asymptomatic, then you can just observe them for about 24 hours and it'll just go away on its own. Remember, coins, they lack sharp borders, and the metal isn't very toxic, so it'll just pass spontaneously. A radiolucent body not visualized on X-ray, however, would then require a CT to be done as the next diagnostic procedure. Some of the things that are more high risk are going to be batteries, multiple magnets, or sharp objects. Now, those have an increased risk of perforation, obstruction, and can lead to ischemia. So you need to do immediate endoscopy if the object is visualized within the esophagus. And then severe symptoms like hematochezia, melena, or severe abdominal pain, then you obviously need to surgically remove them. However, if the problem is a battery is in the distal esophagus, then most of the time, 90% of the time, they pass uneventfully, and in that case you just want to observe to confirm that they have excreted the battery on a stool exam or on radiographic follow-up. You want to avoid giving a GI series because GI series is decrease the visualization on endoscopy. Now, tracheobronchial foreign body aspiration, if it's aspirated within the trachea or bronchi, you want to suspect that in toddlers with sudden wheezing, stridor, coughing, or dyspnea. So they can give you that as a vignette. patient comes in within a couple of hours when the baby just started suddenly having wheezing or stridor or coughing or dyspnea. In that case, you got to think of a tracheobronchial foreign body aspiration. So the procedure of choice would be to do a rigid bronchoscopy. All right, next up is choanal atresia, and choanal atresia is the pathophysiology is that there's failure of the posterior nasal passage to canalize completely, and that's going to leave either a bony or a membranous obstruction. Bony obstruction is going to be the most common, 90% of the time, versus a membranous obstruction is only found 10% of the time, and narrowing is going to be at the level of the pterygoid plate in the posterior nasal cavity. It could be isolated or part of a syndrome called the charge syndrome. So whenever you hear or think of a choanal atresia, think of the charge syndromes that are associated with that as well. So look for colobomas, heart defects, atresias of the choana, growth or developmental retardation, genital urinary abnormalities, and ear abnormalities or deafness. So that's part of your charge syndrome. Clinical severity is going to depend on the child's ability to breathe from the mouth and whether one or both of the choana are obstructed. So if there's bilateral obstruction, that's classically going to present with cyclic cyanosis. That's going to basically mean that the infant's going to be worse and can't breathe through the mouth if they're feeding. And then once they stop feeding, they recover. Versus unilateral choanal atresias, since it's only on one side, that can remain undiagnosed until their first upper respiratory tract infection, which then will show an image of the choana, and in that case, you get your diagnosis of choanal atresia at that point. The diagnosis is going to be failure to pass a catheter through the nares into the oropharynx, and it's confirmed with a CT scan. And in severe cases, air fluid levels can develop at the obstruction site. Now the management is to place the oropharyngeal airway and an orogastric tube for feeding. And the definitive treatment is to repair the obstruction, obviously with surgery or endoscopy. Next up, we're going to talk about congenital diaphragmatic hernias. These present as cyanosis as well as respiratory distress immediately after birth. Patients can present with polyhydramnios because of an esophageal compression. However, the deviation of the abdominal viscera into the thorax is going to result in a scaphoid appearing abdomen, and on X-ray it's going to show a displaced cardiac silhouette with bowels in the thorax and a gasless abdomen. That's pretty easy to see, and sometimes you don't even need to read the whole vignette, and they're going to give you an X-ray. If they give you an X-ray and you see some kind of haustras in your lung, just forget it. That's congenital diaphragmatic hernia. Click and move on. All right, next up is anomalous vascular branches of the aortic arch. These can cause stridor as well as dysphagia, and that's because of compression of that trachea and esophagus by the aortic arch. But the difference here within esophageal atresias that you'll see is that the orogastric tube can be advanced into the stomach. So our next topic is going to be esophageal atresia and a TE fistula, where the tracheoesophageal tube or a tube can't be can't be advanced into the stomach. So there's about 5 different types of esophageal atresias and TE fistulas, but there's one type that you need to remember, and it's your esophageal atresia with a distal fistula. So if you can put that in your mind, that's an esophagus that just stops blindly right there. It just stops. And then if you think of if you see your trachea, the trachea distally is going to have a connection of the esophagus that goes into the stomach. So instead of the esophagus connecting to the top part of the esophagus, or the proximal esophagus, the distal esophagus is going to connect to the trachea, and then the proximal esophagus is going to be, it's just going to end suddenly. So that's why you can't advance a catheter into the stomach or an orogastric tube. That's the most common version of it. There's other ones like isolated esophageal atresia. There's the H-type tracheoesophageal fistula, where the fistula is like in the middle of the trachea and the esophagus, having a connection right there in the middle, and it looks like the letter H. Then you have your esophageal atresia with proximal and distal fistulas, where the proximal and the distal portion of the esophagus connect to the trachea. And then finally, the least common is the reversed version of the most common one, which is an esophageal atresia with a proximal fistula, where the proximal esophagus connects to the trachea. Remember, the most common is going to be that the distal esophagus connects to the trachea, while the proximal esophagus has a blind pouch. All right, so esophageal atresia with TE fistulas, they're also going to present with polyhydramnios. That's due to the inability to swallow amniotic fluid. There's going to be excessive drooling, choking, coughing, and regurgitation with initial feeding attempts immediately after birth. There's also going to be an inability to pass that nasal or orogastric tube into the stomach, like we said. And there's going to be a presence of a fistula, or if there's a presence of the fistula, air entry into the stomach and the intestines are going to occur with each breath. So every time you take a breath in, you get abdominal distension. And then gastric fluid can reflux into the esophagus through the fistula to the trachea and the lungs, causing an aspiration pneumonia. And that aspiration pneumonia can then cause respiratory distress, or the gastric contents can cause respiratory distress, crackles, and pulmonary infiltrates. 50% of patients with tracheoesophageal anomalies have additional anomalies as well. So remember another mnemonic here called your Vactral syndrome, or symptoms, which are vertebral anomalies. There's anal atresia, cardiac problems, TE fistula, renal and limb abnormalities. So if you have one, check for other ones like that. So remember the Vactral mnemonic for the TE fistula, and the charge mnemonic for the choanal atresia. For the choanal atresia. All right. So next up is going to be isolated esophageal atresia, but that's rare and it wouldn't cause any kind of sudden respiratory distress with feeding, because it's isolated, right? So in this case, it's rare and it's probably not going to be tested on, and I only added that for completion's sake. So next up, we are going to talk about GI bleeding, and GI bleeding is going to be divided into upper bleed and a lower bleeding, and the ligament of Treitz is going to be the dividing line. So an upper GI bleed is going to present with melena, which is a black tarry stool from the stomach and the upper small intestine, versus lower GI bleeding. Those are going to present with hematochezia, which is a bright red blood, and that's due to the distal small bowel all the way to the colon. The differential diagnoses of hematochezia in toddlers are going to be hemorrhoids. Hemorrhoids can cause hematochezia, infectious colitis, intussusception, that's a big one, Meckel's diverticulum being the most common, and inflammatory bowel disease. So next up, we're going to talk about milk protein allergies. Risk factors for milk protein allergy or soy protein induced colitis is going to be family history of allergies with eczema or asthma. And clinically, patients are going to present around the ages of 2 to 8 weeks old with regurgitation or vomiting, and that vomiting is non-projectile vomiting. So remember that, non-projectile vomiting and poor weight gain, 2 to 8 weeks with a family history of eczema and asthma, or any kind of allergy, that's probably going to be a milk or soy protein induced colitis. Now, the infant doesn't have to have eczema. So with the clinical features, they could have eczema, but they don't have to. It's the family history that's important. And as they don't have to have painless bloody stools. That could be either painless or painful, or they can have painless, or they can have they don't have to have bloody stools, is what I mean. So they don't have to have bloody stools. They don't have to have eczema. But if they have a family history of allergies or family history of eczema or asthma, and they're presenting with non-projectile vomiting, you start thinking of milk or soy protein-induced colitis. So the treatment here is to eliminate the milk and the soy from the diet. Easy as that. And just exclusively breastfed infants. Or elimination of milk and soy from the maternal diet of an exclusively breastfed infant is what I mean. The treatment is to initiate a hydrolyzed formula fed in infants, and the prognosis is going to be it's going to go away on its own by 1 year of age. The condition is going to be exclusively to the infant. Breast milk is specifically going to contain fats and carbohydrates like lactose and maternal diet derived proteins, specifically whey protein, which is the most common at 70%, versus casein is at 30% from milk and soy. Protein content is higher at birth, and it decreases over the first month of life. Whey is going to be much more easily digested, and it improves gastric emptying. So that's a nice test question that they like to ask, that it improves gastric emptying. And it also contains lysozymes, lactoferrin, and secretory IgA. And all this increases their immunity. Calcium and phosphorus are less in human milk than formula. So formula is going to have more calcium and phosphorus than human milk. But human breast milk is going to be better absorbed. So that's another test question, that the breast milk is better absorbed. Non-IgE mediated immunological responses to proteins in the formula or breast milk is going to cause rectal or colonic inflammation. And diagnosis is going to be clinical, and it's going to be confirmed when the bleeding ceases in response to dietary changes. So that's when you confirm the diagnosis. So the first thing you want to do is to eliminate the diet, and if you see any kind of cessation of blood, then in that case, then it's now confirmed. So visible bleeding ceases in about 3 days, but there can be occult blood that can take up to 2 weeks to go away. So you want to just reassure the patient that the prognosis is excellent, and almost all infants can tolerate dairy and soy products by the time they're 1 year of age. Due to substantial cross-reactivity, though, you want to discontinue all dairy and soy products and continue breastfeeding after you discontinue the milk or soy product. So breastfeeding needs to be continued, obviously. All right, next up is going to be your Meckel's diverticulum. Meckel's diverticulum, the epidemiology here is your rule of twos. There's 2% prevalence. There's a 2-to-1 male to female ratio, so it's more common in males. 2% are going to be symptomatic by the age of 2, and it's located within 2 feet of the ileocecal valve. Clinically, they're going to present with asymptomatic incidental findings, so which is the most common, so they might not even present with anything. They won't present at all, so that's asymptomatic. But they can also have painless hematochezia, and they can have intussusception, as well as intestinal obstructions and volvulus. And the way you diagnose a Meckel's diverticulum is with your technetium 99 protectinate scan. And that's just basically a tiny amount of IV technium is given, and a gamma camera is going to highlight the gastric mucosa, and it's going to highlight the ectopic gastric tissue. So approximately 85% of patients are going to have heterotrophic gastric mucosa, and some can even have pancreatic tissue. That gastric mucosa is going to secrete hydrochloric acid, and that's going to cause mucosal ulceration as well as surrounding ulceration within the small bowel, and that ulceration is going to cause bleeding, often substantial bleeding that will then cause a severe anemia as well as a hemorrhagic shock. Although the bleeding does usually go away on its own, you may need a surgical resection to prevent complications. Intussusception is going to present as a severe intermittent abdominal pain that's going to be with or without hematocatia. So next you'd want to do an abdominal ultrasound, and you diagnose and treat with therapeutic air enema. Alright, so next up is intussusception. So intussusception is risk factors are going to be like recent viral illnesses or rotavirus vaccination. So if they recently got sick or they had a rotavirus vaccination done, that's a risk factor. Pathological lead points, however, are going to be like Meckel's diverticulum. There could be henochshoal impurpura, celiac disease, intestinal tumors, and polyps. So clinically, how does intussusception present? They're episodic crampy abdominal pain and current jelly stools. And they can also have a sausage-shaped abdominal mass. That abdominal mass is going to be palpated in the right upper quadrant. But remember that the actual problem is found most likely in the ileocecal junction that's in the right lower quadrant. But because of the mass gets obstructed and it backs up, then it can be felt all the way up in the right upper quadrant. And when you do an ultrasound, you'll see that target sign, which is telescoping of the intestines, right? And the treatment is to do an air enema or a water soluble contrast. Sorry about that. And or surgical removal of any types of lead points, if there are any present types of lead points. The ileocolic junction is going to be the most frequently involved area. There's going to be telescoping, causing periodic pain associated with legs getting drawn up towards the abdomen. They can have vomiting following episodes of abdominal pain. Initially, that vomiting can be non-bilious, and later can become bilious if the obstruction doesn't go away. It keeps persisting. Then air enema, remember that's preferred. It's faster, it's cleaner, and it's safer than contrast. And but if that doesn't really work, if the air enema doesn't work, and a pathological lead points are going to show signs of perforations, or a pathological lead point is identified, if there's signs of perforations or if there's a pathological lead point identified, then you'd want to move on and to a laparotomy. So air enema first, then if that doesn't work, laparotomy, or if it perforates, do the laparotomy next. Alright, so moving on from intussusception, we're going to go into necrotizing enterocolitis. And in necrotizing enterocolitis, risk factors would be like prematurity, very low birth weight, so less than 1.5 kilograms. There could be a reduced mesenteric perfusion, such as hypotension, a congenital heart disease. Also, enteral feeding, so formula feeding more than breast milk. Those can all lead to a necrotizing enterocolitis. Clinical features are going to be systemically, their vital signs are going to be unstable, and they're going to be lethargic. On GI examination, they'll present with vomiting, bloody stools. They're going to have abdominal distension and tenderness, And on X-ray, there can have something called pneumatosis intestinalis. And that's because of extravasation of bowel gas into a damaged bowel wall. So you get that double line appearance on the bowel wall, or that train track appearance on X-ray. Other X-ray findings would be like portal venous gas, and this would be like a linear branching area of lucency over the liver. Also, a portal venous gas can be either due to bacteria producing the gas in the portal vein, or by the transmission of gas from a bowel wall to a mesenteric vein and then to a portal vein. And also on X-ray you can see pneumoperitoneum. So those are the X-ray findings. So pneumatosis intestinalis, portal venous gas, and pneumoperitoneum. Those are very important for the diagnosis of necrotizing enterocolitis. The treatment would be supportive, so bowel rest, parenteral hydration or nutrition, and then broad spectrum IV antibiotics, because there is high risk of septic shock in these patients. And then surgery can be done. So surgery is with or without surgery. And then complications of necrotizing enterocolitis, like we said, obviously septic shock could be one of them, intestinal strictures, as well as short bowel syndrome, and death can complicate in up to 40% of cases. All right, so common sites are going to be the terminal ileum as well as the colon. Term infants are also going to present earlier, because enteral feeding starts earlier as compared to preterm infants. Also, commercial formulas and breast milk are substrates for bacterial proliferation in the gut. This causes poorly perfused, the wall of the intestines to be poorly perfused, and because of that, there's a decrease in the ability to digest and absorb nutrients. Now, because you have that, then bacteria will start to ferment, causing an excessive mucosal inflammation, and then finally there's translocation of bacteria and gas into the bowel wall. And if possible, you want to give mother's breast milk to premature infants because it counteracts some of the other problems, right? And then leukocytosis and metabolic acidosis are going to be signs of inflammation and intestinal ischemia. And finally, all neonates are going to be frequently colonized by C. diff, but infection is going to be rare in them, probably because there's no toxin receptors for that. All right, cool. Next up, we're going to talk about cyclic vomiting syndrome. So what is the diagnostic criteria for cyclic vomiting syndrome? It's going to be more than 3 episodes in a 6-month period, as well as easily recognizable, stereotypical vomiting recognized to the family. And also it lasts 1 to 10 days. And vomiting occurs more than 4 times an hour at its peak, right? So a lot of vomiting here. No symptoms in between the vomiting episodes, and there's no underlying condition that can be identified with cyclic vomiting syndrome. So there's going to be recurrent, predictable patterns of vomiting, in other words. So you'll see a family history of migraines and headache often is going to be present with them. But the etiology is unclear, although it's thought to be linked to abdominal migraines, which generally present like abdominal pain as a primary symptom. And in some children, it can progress from a CVS to abdominal migraines, right, and migraine headaches. Complications that can arise from recurrent vomiting would be like obviously dehydration and as well as anemia. So those are some of the complications. And the treatment obviously is to hydrate the patient, give them antiemetics like for instance ondansetron, and to reassure the patient, or the parents, sorry, can't reassure the patient, the parents. And children with family history of migraines are going to be likely to benefit from some type of anti-migraine therapy like sumatriptan, in other words. And approximately 2 to 3 have gradual resolution of those symptoms within 5 to 10 years. So that's good. All right, moving on, we have differential diagnoses of vomiting and regurgitation in infants, so this is a really good one. So the main ones here are going to be GERD, milk protein allergy, and pyloric stenosis, right? So let's break them down. So for GERD, there's two types of clinical features. There's the physiological features and the pathological features of GERD, and they both have their own management. So let's start off with the physiological. Clinical features of GERD would be an asymptomatic patient. It just happens, they're happy, that's why they're called the happy spitter, right? Like a camel. Just kidding. All right, and then, so those physiological GERD features, asymptomatic or the happy spitter, the management is to reassure the family and just do position therapy in those cases. However, if there is pathological GERD, you're going to be seeing failure to thrive, so significantly more severe symptoms. They can have irritability, and in that case, their management here would be to thicken up their feedings, also to give them antacid therapy, and if severe enough, you may want to do an esophageal pH probe monitor as well as an upper endoscopy. So that was it for GERD. So it's either physiological or pathological. Now, for milk protein allergy, here they're going to present with regurgitation or vomiting, and they're also going to present with eczema, so a rash and bloody stools. Management for the milk protein allergy is to eliminate dairy products and soy protein from their diet, right? So you want to eliminate what's causing the allergy, like any other type of allergy. Now, and then finally we have pyloric stenosis, which will have a clinical feature of projectile non-bilious vomiting, an olive-shaped mass in the abdomen, like we all know, and dehydration as well as weight loss. And the management would be to do an abdominal ultrasound and to remove it with a pylorotomy. All right, so next up we're going to delve into GERD in more detail. All right, so for GERD, this is extremely common and it affects more than 50% of infants. These infants are going to experience frequent postprandial regurgitation, so they're going to be like spitting up or spilling. And that's due to physiological changes among adults and children. If there is normal weight, growth, and development, but there's no drop in the growth percentile or asymptomatic, then you just go ahead and reassure the patient or the parents. Also give them supportive measures and education. So you have to educate them for frequent small feeding, and you want to hold the infant upright for 20 to 30 minutes after each feed. And you also want to place the infant in a prone position when they're awake. Activities that increase intra-abdominal pressure, like fastening a diaper that's too tight or bringing the knees to the stomach, you want to tell them to avoid those things. The GERD can improve by age 6 or 6 months when the infant can sit up unsupportive, and resolves by 1 year of age. So GERD in infants, there's going to be a short esophageal length. There's also going to be incomplete closure of the lower esophageal sphincter. And that obviously causes stomach contents to reflux into the esophagus. And putting the infant in a supine position also helps to increase GERD, so you don't want to keep the infant in a supine position. That's why you educate them, the parents, to hold them upright 20 to 30 minutes after every feeding. Also, what you should know is that goat's milk is deficient in folate. It doesn't have folate, so you kind of want to avoid goat's milk because it would then cause a macrocytic anemia. So I think that's what I wanted to add on for milk-induced enterocolitis or gastroesophageal reflux. So that's it. So next up we have bilious emesis in neonates. So how do we evaluate? There's going to be an algorithm here, so let's follow this along. So first of all, you have your bilious emesis. If that's the case, what do you do next? You want to stop feeding. You want to do an NG tube for decompression, and you want to give them IV fluids. All right, stop feedings, give them a tube for decompression, and then put them on IV fluids. After you do that, then you do an abdominal X-ray. When you see the abdominal X-ray, you're going to see various scenarios, either free air, hematemesis, or unstable vital signs. That's going to then require surgery. However, if you see dilated loops of bowel within the abdominal X-ray, then you have to, the next best step is to do a contrast enema. And when you do that contrast enema, there's going to be two scenarios. Either there's going to be a specific location inside the rectosigmoid transitional zone, or you're going to see a microcolon. If it's a microcolon, then it's meconium ileus. However, if on contrast enema you see something in the rectosigmoid transitional zone, then you're thinking Hirschsprung's disease. Usually, both meconium ileus and Hirschsprung's disease is going to present within the first 2 days of life with failure to pass meconium. So they could present the same way. Now, next you have on abdominal X-ray an NG tube that's misplaced within the duodenum. So you remember we put that NG tube first for decompression, you do the X-ray, but now you see that the NG tube is misplaced in the duodenum. The next thing you want to do is an upper GI series, and if that's the case, a ligament of Treitz is on the right side of the abdomen. That's malrotation. And then finally, if you see that double bubble sign on abdominal X-ray, that's the easy one. That's duodenal atresia. Okay, next up is volvulus. And in volvulus is the primary predisposing factor for volvulus in children is going to be malrotation of the midgut during early fetal development. Midgut volvulus is going to classically present in a neonate that's less than 1 month old, and they're going to present with bilious vomiting. Initially, the abdomen is going to be soft and it's not going to be distended, but ischemia of the twisted bowel can further on give you bloody stools, as well as abdominal bowel perforation and abdominal distension and peritonitis, right? Signs of ischemia or systemic decompression are going to be like shock, and those are an indication to then proceed on for emergency laparotomy if you see that. The evaluation of clinically stable neonates with bilious emesis is going to begin with the stopping of any kind of entero feeds, right? And you want to do the NG tube decompression and give them the IV fluids like we said earlier. Then you want to do the X-ray. That's generally the first step you want to do. And you do that to rule out a pneumoperitoneum, which then that would reflect an intestinal perforation and the immediate need for an emergency surgery. So that's really the case why you do an abdominal X-ray next. So if you don't see that, then you start looking into dilated loops of bowel, NG tube misplacement, or double bubble signs. Rarely the diagnosis may be suspected if the NG tube is going to terminate abnormally in the duodenum. So so basically a NG tube that's misplaced in the duodenum is kind of rare. But if that's the case, think of malrotation. But the X-ray is usually not specific for midgut volvulus anyway. So if there's no evidence of free air and the bowel gas pattern isn't suggestive of duodenal atresia, which is your double bubble sign, or distal obstruction, like dilated loops of bowel, then you want to do an upper GI series. And you do that with a fluoroscopy, like barium swallow, and those should be performed. The upper GI series is going to be fast and accurate to diagnose a malrotation with a midgut volvulus. So if you're thinking midgut volvulus or malrotation, think of barium swallow with an upper GI series. The finding of the ligament of Treitz that's on the opposite side, or on the right, of the abdomen reflects malrotation, while If you see contrast in a corkscrew pattern that it goes around, that indicates volvulus. And surgery must be expedited to prevent any kind of complication if that's the case. If present, the volvulus is going to be reduced, obviously, and the procedure is called a Ladd's procedure that consists of fixing the bowel in a non-rotated position, and that's going to minimize the recurrent volvulus risk. You also want to do serial abdominal X-rays if, to follow along the progression of any kind of non-surgical case, like if they have ileus or mild cases of necrotizing enterocolitis, if it's just a mild case of that. But it's not recommended in suspected cases of surgical conditions, like for instance a volvulus. All right, next up we have sigmoid volvulus. And the clinical features for a sigmoid volvulus is going to be like abdominal pain, distension, and constipation. And that's due to torsion of the sigmoid colon. An X-ray is going to show an inverted U-shaped appearance of the distended sigmoid loop. And that's going to be your coffee bean sign. So if you ever remember that, the coffee bean sign is the sigmoid volvulus. It typically occurs in elderly patients and is exceptionally rare in children. You also have duodenal atresia, which will present with bilious vomiting within the first 2 days of life. It's common in Down syndrome patients, so that's another one to remember, the duodenal atresia and Down syndrome. And it's due to failure to recanalize. So the only way to treat it is by surgically repairing it. And pre-op cardiac assessment is extremely important because 50% of Down syndrome patients have congenital cardiac abnormalities, right? Like VSDs and ASDs, so you want to do a cardiac assessment pre-operatively. Next one is jejunal or ileal atresia, and those are due to vascular accidents in utero. Those vascular accidents are going to lead to a necrosis and resorption of fetal intestines, and then that seals off that area, leaving behind a blind proximal and distal end of the intestine. The risk factors for this would be poor gut perfusion from maternal use of vasoconstrictive medications or drugs like cocaine or tobacco use. And sometimes meconium ileus or cystic fibrosis will show inspissated meconium that has a localized volvulus that can basically lead to ischemic necrosis. Jejunal and ileal atresia is not associated with any kind of chromosomal abnormalities. Remember, that's due to in utero vascular accidents. It's not a chromosomal problem. And on the X-ray, you see the triple bubble sign, or you see a gasless abdomen. And the treatment would be resuscitation and stabilization with surgical correction. And really the prognosis is going to depend on the length of the affected bowel that's affected and the patient's gestational age and their birth weight. So continuing on, we have infantile hypertrophic pyloric stenosis. And this presents at age 1 to 2 months of age, so 3 to 5 weeks. And the classic findings are going to be like a visible peristaltic wave that's moving from left to right across the upper abdomen just before vomiting, and a palpable abdominal mass as well, which is the classic olive-shaped abdominal mass that's palpated in less than 50% of patients. So it's best felt when the patient's calm after they vomited, because the distended stomach can obscure any kind of mass. So if they have an empty gastric contents, then it's easier for you to feel the mass. However, the abdomen is going to be soft and non-distended because there's going to be minimal air that can pass through that gastric outlet. So that's an easy one. Next up, we have infantile. As we continue on. So infantile hypertrophic pyloric stenosis. Risk factors are going to be a firstborn boy, erythromycin use, and formula feeding. Now the formula feeding is because it slows the gastric emptying and there's more consumption occurring in less amount of time. So there's an increase in gastric burden. So there's more work for the stomach to and the intestines to actually start working, and that can lead to a pylorus hypertrophy, right? So formula feeding, erythromycin use, and a firstborn boy are all risk factors for infantile hypertrophic pyloric stenosis. Clinically, they're going to present with projectile non-bilious vomiting, specifically after they feed, and that's going to follow a hunger. So it's a hungry vomiter is how you should remember it. They have poor weight gain, they present with dehydration, and they can have that olive-shaped abdominal mass. On lab findings, you see hypochloremic metabolic alkalosis, as well as hypokalemic as well. So it's both hypochloremic and it can also be hypokalemic metabolic alkalosis. And the diagnostic study are going to be an abdominal ultrasound that's going to show the thickened pylorus. And the treatment is to give them IV hydration to normalize their electrolyte imbalance before they're rushed to surgery. And this also decreases the risk of post-op apnea and improves overall outcomes of surgery. Wow, I'm really stuttering today. So electrolyte normalization first, and then you can go ahead and do the pylorotomy. So what are some of the laboratory derangements in pyloric stenosis? So they have vomiting, and you want to see if they have loss of hydrochloric acid or loss of sodium chloride and water. So loss of gastric acid is going to cause an initiation of a metabolic alkalosis, hypochloremia, right? If they have, with the loss of sodium chloride and water, they can have hypovolemia, as well as a decrease in renal perfusion pressure. And because of that, angiotensin II goes up, and that is going to cause an increase in aldosterone, increase in hydrogen secretion, and then you're going to have an increase in bicarbonate reabsorption. And also because you have the high aldosterone, there's going to be an increase in potassium secretion. So you have your hypokalemia. So remember how we said earlier, clinically they're going to present as a, they're going to have both metabolic alkalosis, hypochloremic metabolic alkalosis, as well as hypokalemic metabolic alkalosis. Because of that decrease in renal perfusion due to the hypovolemia, angiotensin II is going to increase, causing aldosterone to increase, and aldosterone is going to cause potassium secretion in exchange for sodium and causing a hypokalemia, right? All right. Next up is cystic fibrosis. So some of the clinical features of cystic fibrosis are going to be different systems. So respiratory, GI, reproductive, and musculoskeletal systems affected in cystic fibrosis. So respiratory system, they'll have obstructive lung diseases that can lead to bronchiectasis. They can also have recurrent pneumonias as well as chronic rhinosinusitis. For GI manifestations of cystic fibrosis, there's obstruction in 10 to 20% of the causes, such as a meconium ileus, distal intestinal obstruction syndrome. They can also have pancreatic disease, so exocrine pancreatic insufficiency, and there can also be cystic fibrosis related diabetes in around 25% of the causes. And there's also biliary cirrhosis associated with cystic fibrosis. In the reproductive system, infertility occurs in both men and women. Men, more than 95% of the time, will have infertility, versus women is going to be around 20%. So obviously it's more common to have infertility in men with cystic fibrosis. And musculoskeletal system, they can present with osteopenia that can lead to fractures, kyphoscoliosis, and digital clubbing. Now, Hirschsprung's disease versus meconium ileus. Here's the differentiating features between both of them. So, Hirschsprung's is associated with Down syndrome, versus meconium ileus is associated with cystic fibrosis. Hirschsprung has the level of the obstruction is at the rectosigmoid. Okay, that's for Hirschsprung's, at the rectosigmoid. Versus meconium ileus, it's in the name, it's in the ileum. For Hirschsprung's disease, the consistency of the meconium is going to be normal. However, it's inspissated for meconium ileus, and the squirt sign is going to be positive in Hirschsprung's disease versus that they're not going to have one in meconium ileus. So meconium ileus and Hirschsprung's disease, those should be considered in any infant who fails to pass meconium for more than 48 hours after birth, because 99% normal healthy infants, they pass stool within 48 hours. So if not, start thinking of either Hirschsprung's or meconium ileus. So for meconium ileus, 20% of the patients with cystic fibrosis are going to develop meconium ileus, but all patients with meconium ileus have cystic fibrosis. How about that? So that's what it means is all the patients that have a meconium ileus have cystic fibrosis, but not everyone that with cystic fibrosis develops a meconium ileus. So they also have a narrower, underused, and underdeveloped colon, so that's termed a microcolon, and the obstruction is usually at the level of the ileum. Like we said, it's meconium ileus, so it's at the ileum. The first step in management is to do an abdominal X-ray, and that's always the first step because you want to rule out a pneumoperitoneum. Remember, secondary to perforation, because if perforation is positive, we need to do an emergency surgery. If there's a negative pneumoperitoneum, then you want to do contrast enema. That's used to assess the level of the obstruction. And you also want to administer hyperosmolar enemas like a gastrographin that can potentially break up the inspissated meconium, and it can dissolve that obstruction. And surgery is going to be required if therapeutic enema is unsuccessful. And almost all patients that have cystic fibrosis are going to develop sinopulmonary diseases. And this is going to result in opacification of all sinuses by the time they're 8 months old. If that's the case, they often require surgical debridement of the sinuses. Now, men, like we said earlier, more than 95% are infertile, and that's due to congenital absences of the vas deferens. They like to ask that. So it's because of the absence of the vas deferens, but only 20% of the females have fertility issues. So remember, more common in men for those infertility issues. 20% of patients also develop sensorineural hearing loss due to frequent use of aminoglycosides for those gram-negative infections that they're constantly getting, like for Pseudomonas aeruginosa, for instance. Now, Hirschsprung's disease, that typically presents with increased in rectal tone. That's your squirt sign. Remember what we said, meconium ileus doesn't have a squirt sign. Hirschsprung's does, and that's due to a forceful expulsion of the stool after you do a rectal examination. On X-ray, if there's no perforation, then you want to go and do a contrast enema. Then the area that you're looking for is the transitional zone at the junction of the narrowed rectosigmoid and dilated colon. After that, the next best step is to do a biopsy. So first, a transitional zone contrast enema that shows the transitional zone with the contrast enema. Next is the rectal biopsy. So if you want to back up even more, it's X-ray first, then contrast enema, then rectal biopsy, and if that's equivocal, then you want to do an anorectal manometry last. All right, next up is celiac disease. And some of the risk factors for celiac disease are going to be a first-degree relative with celiac disease, like autoimmune, and then another one would be autoimmune thyroiditis. It can give you a celiac, type 1 diabetes, Down syndrome, and selective IgA deficiency. Symptoms of celiac disease are going to be either extraintestinal or gastrointestinal. Gastrointestinal symptoms would be like abdominal pain, nausea and vomiting, diarrhea, and flatulence or bloating. Extraintestinal symptoms could be like short stature and weight loss. They can also present with iron deficiency anemia and a dermatitis herpetiformis. The diagnosis of celiac disease is going to be made with an increase in tissue transglutaminase IgA, as well as an increase in anti-endomysial antibodies. Endomysial, I always forget how to pronounce that, but an increase in that, in anti-endomysial antibodies. And also a duodenal biopsy is going to show an increase in the intraepithelial lymphocytes and a flattened villi. So those are all diagnostic criteria for celiac disease. All right, moving on, we have constipation. Well, we don't have constipation. Constipation is the next topic. Constipation in children, risk factors would be initiation of solid foods and cow's milk. So if they're starting any of that, that can present with constipation. Toilet training can cause distress and not want to go poop, so constipation, as well as school entry if they the first day of school and whatnot. That can cause constipation. Clinically, they're going to present with straining, with passage of hard stools, crampy abdominal pain, and less than 2 defecations a week. That's pretty bad. Complications would be like anal fissures, hemorrhoids, encoparesis, enuresis, or UTIs, because the stool burden is going to decrease bladder capacity and cause a urinary incontinence. And now the treatment for constipation is to increase dietary fiber. That is a true statement, and there's a question on that one, and that is the best treatment is to increase dietary fiber. You also want to limit any kind of cow's milk intake to less than 24 ounces. And also laxatives, with or without suppositories or enemas. Dehydration is the next topic. Children are vulnerable to dehydration because of increased frequencies of gastroenteritis, also because of high surface area to volume ratios, and that's going to lead to an increase in insensible losses. So because they have more surface area, that can cause an increase in insensible losses, and also the decreased ability to communicate, right? The management is the initial step is to determine the severity of the dehydration. So the ideal method is to determine a measured change in weight. So 1 kilogram acute weight loss is equal to 1 liter of fluid loss. But weight changes are frequently change in children, so it's difficult to determine the last good weight that they had. So severity is determined principally by the history and physical exam, and it's divided into 3 categories. So mild dehydration, moderate dehydration, and severe dehydration. So mild dehydration is going to be about 3 to 5% of volume loss. So they'll have like a history of decreased intake or an increase in fluid loss with minimal or no kind of clinical symptoms. So it's mild dehydration. Moderate dehydration going to have more of a 6 to 9% volume loss. Here we're going to start seeing a decrease in skin turgor, dry mucous membranes, tachycardia, irritability, as well as a delayed capillary refill. That's about 2 to 3 seconds. And there's also going to be a decrease in urine output. Severe dehydration is all the way up to 10 to 15% of volume that's lost. In this case, the child can have cool, clammy skin, delayed capillary refills more than 3 seconds, cracked lips, dry mucous membranes, sunken in eyes, sunken in fontanelles if the fontanelles are still present, also tachycardia, lethargy, and they're going to have minimal or no urine output. And patients can present with hypotension and signs of shock when they're severely dehydrated. So then how would you treat dehydration? Mild to moderate dehydration, you just need oral rehydration as your initial step. For moderate to severe, then you want to do immediate IV resuscitation to restore the perfusion and prevent any kind of end organ damage. Isotonic crystalloids is going to be the only recommended crystalloid in children, like normal saline. Hypotonic solutions, they're not really recommended because they can cause cerebral edema as well as electrolyte abnormalities. And then dextrose solutions aren't given either initially, but they could be added in maintenance therapy. All right, next up we have Reye syndrome, or Reye syndrome is how I remember it. So it's Reye syndrome, R-E-Y-E. Pathophysiology here is microvesicular fatty infiltration. So I know that they trick you there. They're like macro or micro. So it's micro. Reye syndrome is micro fatty infiltration, as well as hepatic mitochondrial dysfunction. The etiology is because they used aspirin, pediatric aspirin use in a setting of, let's say, common influenza or varicella infection. Parents that aren't very educated in the matter give the child aspirin and they present with Reye syndrome. So they're going to present with acute liver failure and encephalopathy. And the lab findings are going to be an increase in transaminases, obviously because of the liver failure. Also, your Pt.2 and INR are going to be increased, and your ammonia is going to be increased. Your liver isn't working, right? So all those are going to increase. Reye syndrome is found in children less than 15 years of age. You want to biopsy the liver, the brain, and kidney. Well, you're not going to want to biopsy it, but if you biopsy the liver, the brain, or the kidney, you see a microvesicular steatosis. And the treatment for Reye syndrome is just supportive. You don't really need to biopsy the brain. Okay, it's just if they biopsy the brain, the kidney, or the liver, what are you going to find? It's microvesicular steatosis. All right, then next up is biliary cysts or choledochal cysts, and this can be congenital or acquired dilations of the biliary tree. It could be single, multiple, intra, or extrahepatic. Okay, so biliary cysts, the pathogenesis here is that you have type 1 cysts, and those are the most common. They're extrahepatic, they have a single cystic dilation of the bile duct, and they manifest with the classic triad of pain, jaundice, and a palpable mass. The majority of the cysts, they're going to present at age around less than 10 years of age. So pain, jaundice, and a palpable mass, right? Diagnosis is done with an ultrasound or an ERCP if obstruction is going to be suspected. And the treatment for a biliary cyst is to surgically resect it, to relieve the obstruction, and to prevent any kind of malignant transformation, right? Jaundice is going to be due to an obstructive jaundice, right? And they're going to present. The presentation varies as with age. So in infants, they can have jaundice and acolic stools, a presentation that's going to resemble also biliary atresia. So it doesn't really tell you much, but they present with jaundice and acolic stools. Older children can have pancreatitis, and then adults can have vague epigastric or right upper quadrant abdominal pain, or they can have cholangitis. So if they have cholangitis, they'll just present with fever. And biliary cysts can transform into a cholangiocarcinoma, so that's very important to manage, treat, and identify. Biliary atresia, clinically, they're going to be well appearing, followed by a development of either jaundice, acolic, or dark urine. So pale stools or dark urine. They can present with hepatomegaly, conjugated hyperbilirubinemia, and mild elevations of transaminases. And that happens within 1 to 8 weeks for biliary atresia. So the diagnosis of biliary atresia, number one, is to do an ultrasound, and that's going to show if the gallbladder is either abnormal or if it's absent. Hepatobiliary scintigraphy is done when there's failure of a tracer excretion, and liver biopsy shows expanded portal tracts with the bile duct obstruction and proliferation. Also, portal tract edema and fibrosis, as well as with inflammation. That's what you'll see on liver biopsy. Now, intraoperative cholangiogram is going to be the gold standard, and that's for, you're going to see a biliary obstruction with an intraoperative cholangiogram. Treatment is either with a hepatoportoenterostomy, which is called a Kasai's procedure, hepatoportoenterostomy, or a liver transplant. And it can have progressive obliteration of the extrahepatic biliary ducts that connects to the liver and to the small bowel. It's most common indication of pediatric liver transplant. So if they ask you what's the most common cause of pediatric liver transplant, which I doubt they'll ask you that way, it's biliary atresia. It also presents within the first 2 months of life with obstructive jaundice and pale stools, acolic stools, and it's conjugated hyperbilirubinemia. If you ever see conjugated hyperbilirubinemia, that's always pathological anyway. Conjugated hyperbilirubinemia, that means that there's more than 2 milligrams per deciliter of direct bilirubin, or more than 20% of total bilirubin. Without treatment, the liver is going to become inflamed, causing hepatomegaly, hepatitis, and ultimately that inflammation fibrosis, and it could be fatal if you don't do the transplant. Virtually all patients are going to require a liver transplant, but the first step is the Kasai's procedure. That's just going to buy some time for growth of the liver and a decrease in mortality and morbidity from the transplantation. Finally, we have physiological jaundice, and physiological jaundice appears after the first 24 hours of life. So within days 2 to 4. Unconjugated hyperbilirubinemia is how it's going to be. Remember, conjugated is pathological. Physiologic jaundice is going to be unconjugated hyperbilirubinemia. And that's due to several physiological differences in bilirubin metabolism. So, first of all, at birth, the red blood cell concentration is going to be increased. The hematocrit is going to be around 50 to 60%. And the lifespan of that red blood cell is going to be very short, around 90 days. So, because of that, there's going to be an increase in red blood cell turnover, causing an increase in hemoglobin and an increase in bilirubin to be spilled out. The bilirubin clearance is very slow because in the liver you need an enzyme called UGT. So that's a uridine diphosphoglucuronidase glucuronal transferase. And that basically, it doesn't reach maturity until about the 2 weeks of life. And then, so because the liver isn't really mature enough to be clearing out a lot of bilirubin all at once, it backs up and causes that physiological jaundice. Also, Asian newborns, they even have lower concentrations of that enzyme at birth compared to other ethnicities. So that's something to be aware of if they present you with an Asian newborn. Don't get mixed up with anything else. Just they're trying to point you in the direction with physiological jaundice, because it's more common because of their the activity of that enzyme is even lower in that ethnicity. Now, sterile newborn guts, when the newborn is the gut in the newborn is very sterile, so it can't break down bilirubin into urobilinogen to be excreted in the stool. So what happens is that there's an increase in enterohepatic recycling of bilirubin. So more bilirubin is then reabsorbed into the gut until the gut is colonized and produces more bacterial enzymes for reduction into urobilinogen. So remember, physiological jaundice, it's usually most commonly benign, and it resolves around 1 to 2 weeks once you get that UGT enzyme working correctly. And you just want to monitor for persistent or worsening jaundice, because remember, high levels of jaundice can cause brain damage. So you want to suggest frequent feedings for gut colonization by bacteria, as well as fecal excretion. and natural sunlight can also decrease bilirubins, but it's not recommended because of the risk of a sunburn, right? So you can do ultraviolet light instead of natural sunlight. Sometimes rapidly progressing hyperbilirubinemia can be treated with phototherapy to prevent kernicterus, but you want to give, it's given if the unconjugated bilirubin is more than 20 milligrams. So if it's really high, then you can start phototherapy. If not, it should just go away. And then exchange transfusion is needed only if the bilirubin levels are way high, over 25 milligrams per deciliter, or there's any kind of neurological impairment. Okay, moving on, we have the timeline of infant nutrition. So this is going to be a timeline from birth to 1 year. So what should be done between birth to 6 months is going to be breastfeeding exclusively. So at 6 months, then that's when you can introduce pureed foods, for instance. But from birth to 6 months is exclusively breastfed. After 6 months to 1 year, they can have pureed food and different other foods. But at 1 year, that's when you can introduce cow's milk. So if cow's milk for some reason is an answer choice, just make sure that the timeline is that the child is 1 year old at least. Now, full-term infants, they don't develop iron deficiency anemia until 4 to 6 months of life, because they're born with a lot of iron storage. And preterm infants with maternal iron deficiency and early introduction of cow's milk is done before they do 12 months of age. If that's the case, they increase their risk for iron deficiency. So if they are given cow's milk before 1 year of age, then it does increase the risk of iron deficiency. Now, if they're exclusively breastfeeding, remember that there is no vitamin D in breast milk, so there's an increased risk of vitamin D deficiency. So you have to give them vitamin D supplementation. And you should also give them iron as well. Iron supplementation should be started as soon as they're born, and you want to continue on until 1 year old if the infant is a preterm. Okay, and vitamin D, you don't need to know how much, but it's 400 units daily. That should be started within the first month of life in infants that are exclusively breastfed. Remember that there's no vitamin D in breast milk. They love to ask that. B12 supplementation is going to be recommended to exclusively breastfed infants when the mom is a strict vegetarian, because how else are they going to get B12? So you need B12 supplements. Pureed fruits and vegetables, those should be introduced first, followed by pureed proteins, so like pureed meats and such. So first you want to do fruits and veggies, then you want to do pureed meats. And there's no type of evidence suggesting that early introduction of highly allergenic foods like eggs, for instance, is associated with an increased risk of allergies. Those foods can be introduced at any time after they're 6 months of age. So you don't have to worry about those foods that may or may not cause allergies. Although some fruits juices, those contain vitamins, but the American Association of Pediatrics, they don't recommend routine introduction of juice into an infant's diet. So juice is never going to be the answer. Actually, here's a curveball situation in your USMLE Step 2 CS. If you haven't done it yet, they do kind of, there was a situation that I had where I had a phone call within the exam itself, and in that phone call, which is one of the patient interactions, clinical interactions, whatever, one of them was a phone call, and they asked the parents on the other end of the phone, the actors, whatever, they said, is it okay to give my child juice? and it's no, that juice will not be recommended to give to an infant's diet. Also water. I think water was, can I give my baby water? And it's like, no, you can't. So for families who choose to offer juice, remember that no more than 4 to 6 ounces per day should be given after 6 months of age, and it should never be given in a bottle, because remember, juice has sugar, so that has an increased risk of dental caries. Just remember that, say no to juice, like OJ. All right, breastfeeding. So breastfeeding benefits and contraindications. So what are some of the benefits to breastfeeding? So maternally, the benefits are that there's a more rapid uterine involution and there's a decreased postpartum bleeding. Also, faster return to prepartum, to the prepartum weight, so they can lose weight faster. There's also improved child spacing, improved maternal-infant bonding, and big one is, because they love to ask this one, it also reduces the risk of breast and ovarian cancer. Because I think that one hits home to the mother who doesn't want to breastfeed or is concerned about breastfeeding for whatever kind of reason. The answer that kind of you want to give the mom is that it reduces the risk of breast and ovarian cancer, because maybe that'll spark interest in her breastfeeding. Now, the benefits in an infant would be that the infant will have improved immunity with breast milk, improved GI function. There can be prevention of infectious diseases like otitis media, gastroenteritis, respiratory illnesses, as well as urinary tract infections. And there's also a decreased risk of childhood cancers, also type 1 diabetes, and necrotizing enterocolitis. So all those are decreased just by introducing breastfeeding. Now, contraindications to breastfeeding. This is a big one. So maternally, there's a bunch of contraindications. So active untreated TB. So if the mom has TB at the moment and it hasn't been treated, that's kind of a contraindications. They can breastfeed after 2 weeks of being on TB therapy, like the RIPE therapy or whatever. After 2 weeks of being on that, then they can go ahead and start breastfeeding. But other than that, it's a contraindication. Another contraindication is maternal HIV infection. So in developed countries where formula is readily available, maternal HIV infection is a contraindication. Herpetic breast lesions. So if there's any kind of herpetic breast lesions, then that's a contraindication. You don't want to spread that. Varicella infection within 5 days or within 2 days of delivery. So that's a contraindication. Specific maternal medications. Chemotherapy, if they're on any kind of chemotherapy or any kind of ongoing radiation therapy, you don't want to do that because that can be transferred onto the baby, as well as active abuse of street drugs like heroin, for instance, or alcohol. All right, so if they're doing any of those things or they have any of those things, those are contraindications. Now, what are some of the contraindications for breastfeeding in an infant? There's only one, and that's galactosemia. So exclusive breastfeeding is going to be ideal form of nutrition for the first 6 months of life. Remember, breastfeeding is going to be always number one. And it's highly recommended. Vitamin D supplementation is recommended until they're able to start eating solid foods, because there's no vitamin D in breast milk. All right, so now we're going to be talking about breastfeed failure jaundice versus breast milk jaundice. I think this trips up a lot of people. Tripped me up for a little while, but it's pretty easy. So the hyperbilirubinemia that occurs in indirect hyperbilirubinemia or unconjugated, that can rise up to 10 to 30 milligrams per deciliter. So when you have breastfeeding failure jaundice, this means that it's in the word. So it's a failure to breastfeed. So you're not breastfeeding enough. It's all about timing. So this is within the first week of life. So if they're not breastfeeding within the first week of life, that's a failure to breastfeed, right? So they get jaundice. So you just rearrange those words and it gives you the answer, the definition, right? So the pathophysiology here is lactation failure that can result in a decreased bilirubin elimination, as well as an increase in an enterohepatic circulation. Also, clinical features could be suboptimal breastfeeding and signs of dehydration because they're not getting that breast milk. So they're dehydrated. So breastfeed failure just means that they failed to give them breast milk. All right. Versus breast milk jaundice. Okay, this starts at age 3 to 5 and it peaks at about 2 weeks. And the reason here is because there's high levels of beta-glucuronidase in breast milk that deconjugates intestinal bilirubin and it increases enterohepatic circulation. So how are they going to present? With adequate breastfeeding and normal examination. So they're going to look normal. They're going to be breastfeeding normally. It's just that because of the high levels of beta-glucuronidase in breast milk, you get the breast milk jaundice that starts at 3 to 5 days. Remember, 3 to 5 days, because later on we'll see the ones that occur immediately or whatnot. So at 3 to 5 days, and it goes away by 2 weeks, that's breast milk jaundice. Now, if they haven't had any type of breastfeeding or they're just not feeding enough, that's breastfeed failure jaundice. So breastfeed failure jaundice, again, it's caused by both maternal and infant factors. It's not that the infant's a rebel. It's because the infant has a poor latch or an ineffective suck or it falls asleep, right? So it's not just drinking, it's just like bored. No, I'm just kidding. So it's just not latching on and it's not drinking the milk. Now, maternal causes would be inadequate milk supply. She can have cracked or clogged nipples or engorgement, breast engorgement, as well as infrequent feeding. That seems to be like the most common cause. So an example like that would be like 4-hour feeding intervals. Normal infants, those pass dark, sticky meconium within the first 2 days of life, after which they should be transitioned to a yellowish or green stool, and that of ingesting adequate milk. So when they're ingesting adequate amount of milk, their stool should start turning yellowish or green. Inadequate stooling will cause a decreased bilirubin excretion and then cause an increase in enterohepatic circulation of bilirubin. So you can't eliminate it, so it's going to just back up. A normal infant during the first week of life has a normal number of wet diapers. Infant ages in days, example would be like 4 days old, would have 4 wet diapers, right? So it's like that. Signs of dehydration would be weight loss. There's a decrease in urine output. Also, on the diaper, you can see brick red urate crystals on the diaper. So how do you treat? The best treatment in otherwise healthy full-term newborns are going to be to increase the frequency and the duration of the feeding to stimulate breast production and maintain an adequate hydration. And you also want to it also promotes bilirubin excretion in the feces. Neonates should start breastfeeding around 8 to 12 times a day for about every 2 to 3 hours for more than 10 to 20 minutes per breast during the first month of life. That's a lot of feeding, but it's got to be done. So remember, around 8 to 12 times a day, every 2 hours, basically. Every 2 to 3 hours, they have to breastfeed. And how long do they have to breastfeed for? About 10 to 20 minutes per breast. Okay, so that ends up calculating to be around 8 to 12 times a day. Closely monitor to ensure the baby is fed adequately. You want to re-monitor them in 2 days, and you want to check that the bilirubin level is decreasing. And if the bilirubin continues to keep rising despite any kind of efforts to optimize lactation, formula supplementation will then be necessary. However, if discontinuing breastfeeding altogether and switching them to formula will further decrease the mother's milk supply and prevent the infant from receiving the benefits of breastfeeding, right? If you don't use it, you lose it kind of a situation, which then includes improved infant immunity and mother-infant bonding. So if you don't breastfeed, there's higher chances of the infant having a poor immunity, and there's no infant-mother bond. Okay, so that was breastfeed failure jaundice. Breast milk jaundice, that is going to be generally a benign condition. Okay, so, but in rare cases, you may need phototherapy, like we said earlier. All right, so Beckwith-Wiedemann syndrome, this is our next topic. What is it? It's a degeneration or deregulation, of imprinted gene expressions on chromosome 11 and 15. Those are two, that's the chromosome you need to remember. 11, 15 is Beckwith-Wiedemann. Physical examination, you're going to see fetal macrosomia with rapid growth until late childhood, an omphalocele or an umbilical hernia, as well as macroglossia and hemihyperplasia. The hemihyperplasia is always something I remember because half of the baby gets really big and swollen, right? The other half is like normal, only half of the baby is big and swollen, so I see it as a baby that's getting wide, so Beckwith-Wiedemann, with, and then wide, man, Wiedemann, Beckwith-Wiedemann. Also macroglossia, they have a big wide tongue, an omphalocele or umbilical hernia, big wide belly button, and yeah, that's it. So complications with Beckwith-Wiedemann would be a Wilms tumor, as well as a hepatoblastoma. And the surveillance here would be to look for serum alpha-fetoprotein levels, as well as an abdominal renal ultrasound. So Beckwith-Wiedemann syndrome, that's a sporadic, or it could be inherited alteration in that gene, remember 11-15, and that encodes for an insulin-like growth factor 2, which is a growth-promoting hormone that's similar to the effects of insulin. And some may have visceromegaly as well, so even the visceras are wide and big. So everything's big. Newborns must be monitored for hypoglycemia, and they should have fetal hyperinsulinemia that can cause a significant hypoglycemia. And usually it's transient, and older asymptomatic patients usually don't require any kind of monitoring. Now, screening for a Wilms tumor and a hepatoblastoma, how do you do that? You can do, like we said, the alpha-fetoprotein, and you can do an abdominal or renal ultrasound every 3 months from birth until about 4 years old. You can also just do an abdominal ultrasound every 3 months until they reach 8 years of age, or a renal ultrasound from 8 years of age all the way through adolescence. The isolated hemihyperplasia, those are also at increased risk of Wilms tumor and hepatoblastoma, and that requires that screening that we mentioned earlier with alpha-fetoprotein. And that is going to be the end of pediatric GI. And we're just going to march on through. Next topic is going to be gastroenterology for surgery. So this might be another big topic here. So we'll continue on. All right, so what are some of the differences between small bowel obstruction and an ileus? So in a small bowel obstruction, you have, the etiology is a prior surgery, so weeks to years, so a surgery that happened a while ago. Versus an ileus, you're going to think of hours to days of a recent surgery. So both are going to be because of a surgery. The only difference is a small bowel obstruction is because of an old surgery that's weeks to years, versus an ileus is a recent surgery within from hours unto days, or days to hours. Also, an ileus can be caused by metabolic problems like hypokalemia, and it also could be medication induced. For an abdominal examination, a small bowel obstruction, that since it's obstructed, it's going to cause distension as well as increased in bowel sounds, versus an ileus. There may be distension, but more importantly, the bowel sounds are going to be reduced or absent altogether. Also, for a small bowel obstruction, and for an ileus, both small bowels are going to be dilated, and the large bowel is not going to be dilated for a small bowel obstruction because it's a small bowel obstruction, and then the dilation happens before the obstruction, right? So the large bowel, which comes after the small bowel, that one's not going to be dilated. Versus an ileus, the large bowel is also going to be affected because there's no movement with an ileus. So for small bowel obstruction, they're going to present with colicky, abdominal pain, and vomiting. They can also have an inability to pass gas or stool, and they're going to have hyperactive bowel sounds as well as a distended and tympanic abdomen. And remember, there can also be an increase in amylase with a mild leukocytosis. Remember that. The diagnosis for a small bowel obstruction, you're going to see dilated loops of bowel with air fluid levels. If it's a partial small bowel obstruction, then you're going to see air in the colon, versus a complete bowel obstruction, that's going to be like a transitional point, which is an abrupt cutoff, right? With no air in the colon. So if air in the colon if air is able to escape and go into that colon, then that's a partial obstruction, right? Obviously it's partial because a little bit of air went all the way to the colon. If there's a complete obstruction, then there's no air in the colon. I don't think that's an important point, but just to better understand that. Complications: ischemia, necrosis is caused by strangulation, and so that could be a small bowel obstruction complication, ischemia or necrosis due to strangulation, as well as bowel perforation. And the management would be bowel rest, a nasogastric tube suction, and IV fluids. And you can also manage with surgical exploration for signs of any kind of complications. And it's characterized by anatomical location. Remember, proximal versus mid versus distal. Or it could be either simple obstruction versus a strangulated obstruction. So remember, a complete proximal obstruction, there's going to be early on vomiting, abdominal discomfort, and an abnormal contrast filling on X-ray. If it's mid or a distal obstruction, the abdominal pain is going to be colicky. And there's also going to be delayed in vomiting. So the early vomiting is a complete proximal obstruction. So think of vomiting, you have to vomit through the mouth, that's a more proximal location. Mid or distal, the vomiting is not going to happen because it's more distally. So it's going to take longer to get to the mouth, so delayed vomiting. Prominent abdominal distension is also seen with mid or distal obstructions. Constipation or obstipation. And the obstipation is only seen if it's severe or if there's a complete type of constipation or obstruction. And hyperactive bowel sounds are heard, as well as dilated loops of bowel are seen on an abdominal X-ray. For a simple luminal occlusion, you don't need antibiotics, but obviously if it's strangulated or complicated, there might be some loss of blood supply to the bowel wall, and that increases the risk of ischemia or strangulation, and if it leads too long with that going on without being treated, that can lead to necrosis. There could be peritoneal signs like rigidity or rebound tenderness. So there's going to be changes in the character of the pain. Signs of shock. How are they going to present if they're thinking shock? Remember, that's always easy. Fever, tachycardia, leukocytosis, and there's going to be significant metabolic acidosis. But the metabolic acidosis is going to be like a late finding. If you see any of that, you're going to need to do an emergency abdominal exploration. Anytime you have shock, that's an emergency. So if not done, that increases the risk of perforation, and obviously if you perforate your bowels, there's going to be an increased risk of mortality, or an increased mortality rate. And the causes here would be surgical adhesions. Remember the surgeries that happened weeks to years beforehand? That causes the adhesions. It's the most common cause. It could be congenital, however, in children, so think of LADS bands. But commonly it arises from abdominal operations or any kind of inflammatory processes. All right, moving on, we have paralytic ileus. So paralytic ileus, they present with nausea and vomiting. It's a failure to pass stool or gas, that's obstipation. Whenever you can't pass gas, that's obstipation. There's some degree occurs following most abdominal procedures, but surgery or symptoms are going to be around 3 to 5 days post-op. So 3 to 5 days post-op, that's when you start seeing the signs and symptoms of a paralytic ileus. This is other causes would be like retroperitoneal causes like abdominal hemorrhages or inflammation, as well as intestinal ischemia and electrolyte abnormalities can all lead to a paralytic ileus. The pathophysiology is that there's an increased splanchnic nerve sympathetic tone following peritoneal instrumentation. So whenever the peritoneum gets irritated by instruments, it can cause increase in splanchnic nerve sympathetic tone. And that then causes local release of inflammatory mediators, as well as postoperative opioid analgesic use. That's a big one also, which causes a decrease in gastrointestinal motility and causes a disordered type of peristalsis. It's going, but it's not very orderly. How do you prevent is by doing epidural anesthesia. So as long as the anesthesia is localized maybe to the spinal cord or whatnot, and it doesn't get into the gut, then epidural anesthesia would be a good way of preventing a paralytic ileus. However, minimally invasive surgery can also do it, and judicious perioperative uses of IV fluid. So you kind of want to give them lots of fluid to minimize GI edema. All right, and then the diagnosis is clinical. It's clinical mainly. So abdominal X-ray findings are going to show dilated loops of bowel, and there's no real transition point here. And the treatment is just mainly conservative, and that includes bowel rest and supportive care, as well as treatment in secondary causes. All right, next up is a nice one that they like to ask is dumping syndrome. So what are the symptoms of dumping syndrome? And this is abdominal pain, diarrhea, nausea, kind of like if you ate bad food or something, and suddenly you have all these symptoms: abdominal pain, diarrhea, nausea. You get hypotension and tachycardia, dizziness, confusion, fatigue. You start sweating. It's kind of like a really bad scenario. It could be really disturbing to some people. And the timing here is that it happens between 15 to 30 minutes after a meal. And why is this happening? Is because there's rapid emptying of gastric contents that are hypertonic. Okay, so how do you manage this is by having the patient not eat huge meals and just do small frequent meals. And you want to replace simple sugars with more complex carbohydrates. So and you want to incorporate high fiber diets as well as protein rich foods. And you also want to drink fluid between those meals rather than during a meal, because you're just increasing more volume than necessary in someone that is prone to having dumping syndrome. Now remember, this is a common cause that happens after you do a gastrectomy. It's a common complication. It occurs in 50% of those cases. For instance, my mom, she had a gastric bypass, and she gets dumping syndrome on a regular basis, and it really sucks. So yeah, any kind of post-gastrectomy procedure can cause this complication, and it's loss of normal action of the pyloric sphincter due to an injury or a surgical bypass, and that then causes the rapid emptying of the gastric contents and causes hypertonic gastric contents to go straight into the duodenum and into the small intestine. And because of that, you get this fluid shift from the intravascular space into the small intestine, and because of that very quick fluid shift in there, you get hypotension and stimulation of autonomic reflexes that increase the release of intestinal vasoactive intestinal peptide, the VIP. So the diagnosis here is clinical, although upper GI X-ray series or a gastric emptying study, they could be helpful in the diagnosis, but only if it's really unclear. But it's pretty clear when this is happening. But just so you know, it's going to be a clinical diagnosis. Symptoms is that it's going to diminish over time. The minority of the times is going to be due to refractory symptoms that they can benefit from trials of octreotide or another surgery like a reconstructive surgery, but usually that's not really needed. You basically want to just educate the patient and tell them to have small, frequent meals. Replace those with those simple sugars with complex carbohydrates, and start incorporating more fiber, more protein-rich foods, and try to not drink water or fluids with your meal. Just do that beforehand. Okay, peritonitis is our next topic. So how do we manage it? Number one is with pre-op nasogastric decompression. Number two is you want to manage it with IV fluids and antibiotics. And if the patient is on warfarin, then you want to reverse the anticoagulation by restoring vitamin K dependent clotting factors with fresh frozen plasma. And there's also going to be emergency laparotomy as the fourth step in management. So those were the managing peritonitis, which is, let me run those through again. Pre-op nasogastric decompression, give them IV fluids and antibiotics. If a patient is on warfarin and has peritonitis, you want to reverse any kind of anticoagulation by giving them and restoring their vitamin K dependent coagulation factors by giving them fresh frozen plasma. And then finally, emergent laparotomy. Next up is blunt abdominal trauma. They like to ask this on the UWorld. They like to ask a lot of ATV accidents or automobile accidents where you crash up against like the handlebars into the gut or whatever. So abdominal trauma, blunt abdominal trauma. This is most commonly are going to be the liver and the spleen that are going to be affected. So retroperitoneal organs like the pancreas and the duodenum, those are going to be less commonly affected. There's also going to be hypotension after blunt abdominal trauma, but if that's the case, that suggests a solid organ or a vascular injury. So if you see that hypotension after an abdominal trauma, start thinking that there's something broke inside, right? Splenic laceration, but they can have hemodynamic stability and no evidence of other kind of intra-abdominal injury. That, if that's the case, it may be a non-operative management case. That's your best case scenario. If there are signs of splenic lacerations, those can appear later on, and the initial, but the initial evaluation may be unremarkable. So initially, you may not have any kind of signs of splenic laceration, right? That happens later on. If they're hemodynamically stable, you want to do a fast. If the fast is negative, then you want to do a CT with contrast, and that's the diagnostic modality of choice because that's going to identify if there's any kind of splenic lacerations with good accuracy. The CT with contrast. Also, you want to determine the need for surgery, especially of the spleen, if there's any kind of splenic rupture or whatever. If there's hemodynamic instability, even after giving them fluid resuscitation, you just go straight into urgent laparotomy. Forget about the fast. They need to be hemodynamically stable first. So if they don't get any kind of stability with fluid resuscitation, then straight on to the urgency laparotomy. But if they're hemodynamically stable, then that's when you do the fast. And if the fast is negative, then you do a CT with contrast. All right, and you want to do that because you want to find out if there's any kind of splenic laceration. So let's go through an algorithm of the management of blunt abdominal trauma in a hemodynamically unstable patient. Okay, so if they're hemodynamically unstable, before I said that was you want to do fluid resuscitation, but here it starts off as fast examination. So so I'm just gonna, maybe I miswrote that. So let me just go here. This is something I wrote directly from the algorithm on UWorld. So if there's a hemodynamically unstable patient with blunt abdominal trauma, you do the fast examination. If it's positive, you want to do laparotomy, basically. If it's inconclusive, then you can do peritoneal lavage, and if it's negative, then you want to see if there's any kind of signs of extra abdominal hemorrhages, like pelvic or long bone fractures. And if that's the case, if there is kind of a fracture of a long bone, you want to stabilize them with either angiography or by splinting them. If there's no types of fractures or abdominal hemorrhaging, then you want to stabilize them and then do a CT of the abdomen. Okay, so yeah. So then what should we take from this? Diagnostic peritoneal lavage is what we should take out of this, because it's kind of obvious that if there's anything wrong in the fast examination, you want to do a laparotomy, and if it's fine, if it's negative, then you can just go ahead and either stabilize them with a splint angiography or do a CT of the abdomen. But what if it comes back, if you do the fast and it comes back that you have no idea, you still have no idea, then the next best step is to do a diagnostic peritoneal lavage. That is the only indication for diagnostic peritoneal lavage, is if you did the fast examination and it comes back inconclusive. I did have a question on that, so just remember that. So some of the features that are suggestive of an intra-abdominal injury could be like hypovolemic shock, the seatbelt sign, right, on the abdomen. You see the seatbelt markings across the abdomen. Abdominal distension with guarding, also rebound tenderness with concomitant femur fractures. So a fast is going to be focused assessment with sonography for trauma. That's what FAST stands for. So that's a convenient and effective test that's done bedside to determine if there's any kind of free intraperitoneal fluid in that hepatorenal space, or it can in the splenorenal recess, or in the inferior portion of the intraperitoneal cavity. So so when you combine it with the evaluation of the pericardium, that's a complete fast examination. So fast, focused assessment with sonography for trauma. For a diagnostic peritoneal lavage, remember that determines the presence of any kind of an intra-abdominal hemorrhage. If aspiration of 10 milliliters of peritoneal fluid shows blood, then you want to do an intra-abdominal. Then that tells you that there's an intra-abdominal injury. If there is no gross blood found, then you want to perform peritoneal cavity lavage with normal saline, and then you want to send that out to the lab for analysis, for red blood cell analysis. But more importantly, they're going to ask, when is diagnostic peritoneal lavage indicated? And it's only indicated after you've done a fast and it comes back inconclusive. All right, next up we have duodenal hematoma. And that's most commonly follows a direct blunt abdominal trauma. It's most common in children, and the blood is going to collect between the submucosal and the muscular layers of the duodenum, causing an obstruction, and then epigastric pain, and finally vomiting. CT with oral contrast is done. That's the investigation modality of choice, CT with oral contrast. And the management is that it resolves spontaneously within 1 to 2 weeks when you have a duodenal hematoma. The intervention of choice is going to be nasogastric suction and parenteral nutrition. But if that fails, then surgery is done, specifically a focused laparotomy or a laparotomy to evacuate that hematoma. So remember that hematomas can commonly be found in children, and it's after a blunt abdominal trauma. So if you see that, think of duodenal hematoma. And then finally, we have pancreatic lacerations, which happens because of a blunt abdominal trauma again. But then there's compression of the pancreatic neck or the pancreatic body against the spinal cord, the vertebral column, or not the spinal cord, the vertebral column, over which it lies, right? So if that's the case, you can have pancreatic contusions, a crush injury, laceration, or a transection may result. Abdominal CT is going to be done immediately after trauma, and it may not detect pancreatic injury. So you're going to need serial CT scans to detect an evolution of the injury, like an enlargement of a gland, any kind of parenchymal disruption, or areas of diminished contrast perfusion and peripancreatic fluid collection. Now, amylase values, those aren't very specific, and they're not going to aid in your diagnosis. If blunt traumatic pancreatic injury is undetected at first, you want to devitalize tissue or pseudocysts resulting from such injury can become secondarily infected. So what I'm trying to say is that when you have a traumatic pancreatic injury, there can also be devitalized tissue or a pseudocyst that occurred after that injury. And that can then become infected, so that patient can present with fever, chills, and deep abdominal pain. Now, a pancreatic abscess, this can lead to this is a serious complication that can lead to an increase in mortality. So a pancreatic abscess really is no joke. The treatment for a pancreatic laceration is to immediately place percutaneous drainage, a drainage catheter, and to culture that drained fluid, as well as to do a surgical debridement. So that's what you need to do for a pancreatic laceration. All right, continuing on, we have appendicitis. So how do we examine an appendicitis? There's going to be several signs. There are going to be peritoneal signs like rebound tenderness, involuntary guarding, and abdominal rigidity. So all this is just an acute increase in pain after you remove the hand when you apply pressure. There could be tension of the abdominal wall, and if that tension persists, that can cause abdominal rigidity, right? The significance of all this is a peritoneal irritation. It could be because of a rupture or some kind of impending rupture. So those were the peritoneal signs. Now for a psoas sign, this is your right lower quadrant pain when you extend the right thigh. There you can, the reasoning behind this is there could be an abscess that's adjacent to that psoas muscle, or it could be a retrocecal appendix, right? So that's the psoas sign. Obturator sign is when you have right lower quadrant pain when you internally rotate the right thigh. So it's kind of like put your knee inward. That's the obturator sign. That's also a significant for an appendix, for a pelvic appendix or an abscess. Moving on, we have a Rovsing sign. If you've heard of this, this is more for acute appendicitis. This is right lower quadrant pain and left lower quadrant pain when you palpate. And then finally, rectal tenderness is right pelvic pain when you do a rectal exam. So that's also going to be significant for a pelvic appendix or an abscess. So this appendical abscesses, if they're present for more than 5 days, like appendicitis is happening on for more than 5 days, this can lead to a contained abscess. So how do you diagnose this? With a CT scan. And if the patient is stable, then you just have to give them bowel rest, IV antibiotics, and possibly you can drain the abscess if it worst comes to worst. But remember, because they're stable, you want to just limit them to IV antibiotics, bowel rest, and drainage if at most necessary, because urgent surgery has increased risks of complication. And a patient can return 6 to 8 weeks later on for an elective appendectomy if they wish. All right, moving on, we have psoas abscesses. So clinically, how do these present is with subacute fever, abdominal pain or flank pain that radiates to the groin. They can have anorexia with weight loss, abdominal pain with hip extension. That's the psoas sign, like we said earlier. And the diagnosis is done with a CT scan of the abdomen or pelvis. Leukocytosis and elevated inflammatory markers are seen. Also, you're going to have positive blood cultures for the abscess, right? As well as thrombocytosis in some cases. And the treatment for a psoas abscess is to drain it and to give them broad spectrum antibiotics. So psoas abscesses, these can occur from hematological seeding from a distant infection, or it can be a direct spread from an intra-abdominal infection like a diverticulitis or a vertebral osteomyelitis. So it could be just direct spread from there. The risk factors for a psoas abscess are going to be HIV, IV drug abuse, diabetes, and Crohn's disease. And these can present with non-specific symptoms, so it should also be considered as part of an evaluation for fever of unknown origin. So if somebody's just having a fever you don't know, a psoas abscess is a good differential to have. So when you deep palpate the area, that's needed to elicit the pain because it's really deep in there. And in patients with unexplained a psoas abscess, a colonoscopy may be needed to find out what the source of the abscess is. A retrocecal appendicitis can also cause the psoas sign. So remember that one, the retrocecal appendicitis. But the pain is elicited by rectal exam, and it's not localized to the right lower quadrant. So it's more like they're having a rectal exam and then they have the pain. All right. So next up, we have pyloric disease. So this is common in young males with larger amounts of body hair. So etiology of pyloric cysts or sinuses, this is unknown, but it's believed to develop because of chronic activity involving sweating and friction of skin overlying the coccyx within the superior gluteal cleft. The infection of the hair follicles in that region, that can spread subcutaneously and form an abscess. And that abscess can rupture and cause a pyloric sinus tract, right? Chronic sinus tract can then collect hair and debris, and that hair and debris can result in a recurrent infection and foreign body reactions. So it's like an infection of a hair follicle, in other words, in the coccyx. So when the sinus becomes acutely infected, they're going to have pain, swelling. You can have even purulent discharge in the midline post-sacral region, and that's your sacrococcygeal skin. And the treatment for pyloric disease, obviously, is to drain the abscess and excise the sinus tract. All right, next up we have anal fissures. And for anal fissures, the etiology is going to be local trauma to that area. So like constipation, prolonged diarrhea, and anal sex. Inflammatory bowel disease like Crohn's disease and malignancies can all cause anal fissures. How they present with pain with bowel movements. They can have bright red blood on the toilet paper or stool surface. And it's most common at the posterior anal midline. They like to ask that. It's at the posterior anal midline where you have those anal fissures. It's a longitudinal tear in the anal canal that's distal to the dentate line. A chronic fissure can have a skin tag associated with it at the distal end. So it's another one to look for. The treatment for anal fissures is to start with the obvious factors there. It would be to soften the stool with a high fiber diet, adequate fluid intake, stool softeners, also a sitz bath, and topical anesthetics, as well as vasodilators like nifedipine or nitroglycerin. Those are all good for anal fissures. Next up, we have post-op cholestasis. And this is a benign condition that often develops after major surgery that's characterized by hypotension, as well as extensive blood loss in tissues and massive blood replacement. Jaundice is going to be thought to develop secondarily to 3 factors. So you have increased pigment load caused by a transfusion, a decrease in liver functionality caused by a hypotension, and they can have decreased renal bilirubin excretion caused by tubular necrosis. It's generally, the jaundice is going to be evident by the 2nd or 3rd day of a prolonged surgery, with bilirubin levels that peak all the way up to 10 to 40 milligrams by the 10th postoperative day. And alk phos levels can also be elevated, as well as AST and ALT levels, but normally the AST and ALT levels are going to be normal, or it's just slightly elevated. But remember, the alk phos is going to be elevated. And that is it for peds gastro, or surgery gastro. We're going to follow this up lastly with GI gastroenterology for obstetrics and gynecology. So let's start her up with liver disorders that are unique to pregnancy, right? So some of the unique pregnancy liver disorders are going to be ICP, which is intrahepatic cholestasis of pregnancy, also the HELP syndrome, and acute fatty liver of pregnancy. Those are the 3 most common ones. So for intrahepatic cholestasis of pregnancy, remember, they're going to have intense pruritus, right? So the patient's going to be pregnant with a lot of itching, and on lab findings, you're going to see an elevated bile acids. You're going to have elevated levels of liver aminotransferases, and it's basically a diagnosis of exclusion. So that's intrahepatic cholestasis of pregnancy. For HELP syndrome, that's a little easier. They're going to present with preeclampsia, right upper quadrant pain, as well as nausea and vomiting. And on labs, you'll see hemolysis, moderately elevated liver enzymes, as well as thrombocytopenia. Right, so that's the actual reason, the word HELP. Hemolysis, elevated liver enzymes, and low platelets, right? Okay, then you have acute fatty liver of pregnancy. So for acute fatty liver of pregnancy, they're going to present with malaise, and they're also going to present with right upper quadrant pain, nausea and vomiting, and a sequel of liver failure. Okay, on lab abnormalities, they're also going to present with hypoglycemia, mildly elevated liver aminotransferases, elevated bilirubin, and possible DIC. So that's one for acute fatty liver of pregnancy. They can have a possible DIC. All right, so let's break these down a little bit more into detail, starting with intrahepatic cholestasis of pregnancy. Remember, this is a functional disorder of bile formation. It develops usually around the 2nd and 3rd trimester of pregnancy, so it's later on in the course. And the etiology is really unclear, but it's thought to be due to hormonal changes. So there's due to like increased levels of estrogen and progesterone later on in the pregnancy. There's also going to be genetic and environmental factors that can influence this as well, but remember, they're not going to ask you this because it's unclear what the etiology is. On clinical features, they'll have intense itching, often intolerable itching, generalized itching, especially in the palms and the soles, and it's worse at night. And there's evidence of skin excoriations can be present as well on exam. But less than 10% have jaundice, and they require further workup. So What you need to know here is that it almost seems like they have some kind of bile problem, but it's really not known why it's going on, but they have just intense amount of itching. But the bile acids are going to be increased, but they can also be maybe the only abnormal lab findings would be an increase in total bile acids. The LFTs are sometimes suggestive of cholestasis with increase in alk phos, and total and direct bilirubin levels are also going to be increased. Although alk phos is increased in normal pregnancy anyway, so that's not going to tell you much. Serum aminotransferases can be up to 10 times the limit of normal, so I would say more than 1,000 at times. And there's going to be need of viral serology. The treatment here would be for symptom relief of the itching. They're coming in because of that, so you kind of want to treat their itching, which follows weeks after delivery. Ursodeoxycholic acid is frequently prescribed to increase the bile flow, and that relieves the itching. So remember that, ursodeoxycholic acid. And the maternal prognosis is basically good. However, early delivery is recommended once the fetal maturity is going to be achieved to avoid any kind of fetal complications like intrauterine demise or neonatal respiratory distress syndrome. Next up is acute fatty liver of pregnancy. This is a rare illness that can present later on in the 3rd trimester. And this ultimately develops with liver failure and extrahepatic manifestations like ascites. They can have jaundice and hypoglycemia. They can have encephalopathies. They can also have severe coagulopathies as well as acute kidney injury. But pruritus is not really a common feature for acute fatty liver of pregnancy. And on labs, you're going to see a consistent labs that are closely related with liver failure. Next up is going to be pruritic urticarial papules and plaques of pregnancy. And that's a skin condition that develops in the 3rd trimester. Classically, the findings on abdominal examinations are going to be red papules with striae with sparing around the umbilicus. And sometimes it extends all the way to the extremities. The palms and the soles and the face are not going to really be involved. And it helps that distinguish it from intrahepatic cholestasis of pregnancy, where you do have a rash in the palms and soles and the face. There's no laboratory or liver abnormalities associated with pruritic urticarial papules and plaques of pregnancy. Say that 3 times fast. Acute appendicitis in pregnancy. Now, this may lead to rupture of the appendix if the diagnosis is delayed. So if you delay it for more than 48 hours, that can actually cause a rupture of the appendix. Patients are going to present with nausea and vomiting, which mimics pregnancy symptoms anyway. So that's kind of hard to diagnose with that on its own. Also, right lower quadrant pain is going to be the most common feature, but the location could be higher depending on the gestational age of the pregnancy, right? Because of the actual pregnancy, it's causing the location to be higher. Fever may or may not be present, and there's going to be an increase in leukocyte count present in an appendicitis or in a normal pregnancy anyway. So again, this is a little bit harder to pinpoint. An ultrasound with graded compression techniques, which is a non-compression and dilation of the appendix, is diagnostic. And the best initial diagnostic technique to rule out other causes, non-visualization does not exclude appendicitis. So the ultrasound with graded compression, that's going to be the best imaging modality. If the ultrasound is not diagnostic, then an MRI can be done to further assess for possible appendicitis. Also, if the ultrasound is not diagnostic and the MRI isn't available, then the only thing you can do left is to do a CT. And if that's the case, then you have to do a diagnostic laparoscopy as your last option if you don't see anything on the CT. you need to move on as the last option, a diagnostic laparoscopy with, and that's it. And that's a lower midline vertical laparotomy. All right, guys, so that is the conclusion for peds gastro, surgery gastro, and OB-GYN gastro. So for, let's just recap OB-GYN. The main ones are going to be intrahepatic cholestasis of pregnancy. So just remember a pregnant woman with intense pruritus, HELLP syndrome, and that acute fatty liver of pregnancy, which shows up like a liver failure in pregnancy. That's kind of what it looks like. And they all basically happen within the second and third trimester of the pregnancy. So if they give you a patient that's happening in the first, I wouldn't pick any of those. And that's it. So thanks again, guys, for listening in. Hope this has been useful and helpful to you, and look forward to keep on doing these video audio lectures for you. So comment below on what else you'd like to like me to go over. I'm thinking maybe rheumatology next, or dermatology. So anyway, thanks guys, good luck on your exams, and see you next time. Bye.